Okay, let's start off with tractions that's unique to children. Again, Ms. Medley's going to go over all the different tractions that are mentioned in the Peds book, but these are the ones that you're going to see used most often with children. What is traction? It's where the body weight provides counter traction, which is a backward force, and the patient's contact with the bed is going to constitute the frictional force. What is traction used for? It's used for a lot of different things. It can be used to fatigue muscles to try to get them to go into to relax down and possibly help with the pain and growth of those muscles. It can be used to, of course, stabilize, and there's a whole list in your book, and there's 6 primary purposes for them. But hopefully, it's going to help us make sure that our bones can be realigned. It's going to help us prevent contracture deformity and reduce muscle spasms, especially in children, because a lot of times they'll have muscle spasms from uh, being in the cast. Well, no, it's not especially in children. It's more in adults. Children very rarely have muscle spasms. It's been a long week. I bet y'all feel the same way, and we're both, all of us are going to be in clinical tomorrow and Sunday, and we've worked all week, but we're going to do it. We're going to look forward to it. We're going to have a good weekend. All right, back to the traction. Bright traction is one that we see used. It used to be where the only time you would see children in this traction would be at Children's Hospital. Uh, it's considered a dangerous traction as far as aspiration of the child, because the child has to lay exactly flat with the legs in the air, like you see this little child here. He is in a portable, or she is in a portable Bryant traction, so that they can move. They pick up the whole traction portion, and the baby, of course, is small enough that he's on the bed portion, and they can actually fit it into this wagon, and they can move him around to help with his environmental things and socialization and everything else that he needs. So um, Brian is considered a running traction, and the pull is only in one direction. The buttocks have to be elevated off the bed at all times. If the buttocks is touching the bed, um, then you are not getting your traction that you need to pull those hips. This is usually used for DDH, developmental dysplasia of the hip, in infants who are older than 12 weeks. So the buttocks, of course, has to be off the bed. Because the aspiration risk is so high in these children, RNs should be the ones that take care of babies that are in Bryant's traction. It looks like it would be a very easy thing to do. You would think, hey, let the LPN take care of this kid, but that is not how it works with the Bryant's traction. The pelvic cornice, on the other hand, looks really complicated, but the care is not as complicated, and it doesn't have any high risk factors as far as aspiration or anything. So we like to put the pelvic harness on. Again, this is used for developmental dysplasia of the hip. As soon as we diagnose the baby, we want to put this particular traction on. And we normally want to get this on them from the time that they're born up until they're about 12 weeks old. So if they're, this of course places them in adduction, puts their hip in adduction, and it holds them in there so that the femur is in the cerebellum. It uses motion and gravity to put that hip in an abducted, reduced position. If this doesn't work within the 6 to 12 weeks, we then go to the Bryant's traction. And the Bryant's traction is used up to the age of 6 months. So At 6 months of age, if there's not been enough improvement, then they're going to do surgery. But I'm just wanting you to know right now, we're going to talk a little more about hip dysplasia. It has to be worn continuously. The parents do not need to make any adjustments of this harness. Baths can be given bed baths can be given. Sometimes the doctors will let you take it off and then put it back on for a bath once a week or so, but it has to be on continuously in order for it to work. The baby can still move. It just holds the hips in abduction. Um, it's not very. It's a soft brace, but what you need to make sure that you're watching for is reddened areas under the strap. So you want to assess that quite frequently. Then we have the Dennis Brown splint or traction. This is done after after you've had serial casting of the baby's feet for clubfoot, and you have them in the alignment, and you want them to stay in alignment. The Dennis brace is used to keep them in alignment. Of course, it puts the hips in abduction, and it's fitted to the baby's foot. And you'll notice that the toes are missing out of the shoes, and that's normal. Um, Parents can cut the toes out of shoes that are going to be used. The doctor would prefer you cut them out before before they change them, because it's something that they don't. I don't think they actually do in their. Um, but the toes do need to be cut out to provide for the foot to grow. When the shoe looks like it's too tight, the you need to take them to the therapist and have a new pair uh, and have them replaced. And a lot of times they have special shoes already that if you can afford to buy them, they'll buy those shoes. So just be sure that the toes are out. And normally they lace up or they Velcro so that it's easy to get the child in and out of the shoe. Um, should always wear socks to prevent sores from developing. And don't use the bar to pick it up to change the baby's diaper. Uh, Try not to do that. Be easy to do that. I know I'd probably do that. That would be bad of me. Okay, then we're going into birth and developmental defects. We're going to talk about the hip dysplasia, DDH. We don't know what causes DDH, but we are suspicious of certain things. We think that it has something to do with gender. Females get it more than males. Can even be birth order. Can be family history. Interuterine positioning. So usually the physiological factors that we're looking at is going to be that maternal hormone secretion. Remember we talked about the relaxin hormone that relaxes mom's pelvis. Well, it relaxes baby's pelvis as well. So if there's a whole lot of that going on, it can actually cause too much relaxation of the femoral head, and it comes out of the cerebellum. Intrauterine positioning also has a lot to do with that. If they're in a breech position, if their feet are turned in and there's not much room in there, if there's not enough fluid, things can do that. Large infants and mechanical factors, breech delivery, and then of course there is the genetic factors. Usually if you've got some family members that have had problems with clubfoot, you will see that developing uh, in your offspring. So it really can be have a little bit of a genetic accommodation there. How do we know they have developmental hip dysplasia? I know we went over this in OB, but let's go over it here because it's here. We can do the ortolani or the Barlow test in that first 4 weeks of age. And there is a picture in your book that shows you the how to do those exams, and that's on page 1069. No one should do the ortolani or the Barlow that's not been properly trained. So usually the nurses don't do this unless the doctors have trained them to do it. So first thing you're going to look at are those uneven, when you are assessing your baby. Does he have asymmetrical gluteal folds? Usually there's more folds on one side than on the other. And you can see it from the front or the back. So with the ortolani, you're going to have them lying flat, and you're going to see if you hear that audible click. So the audible click is what you're looking for. With the Barlow, you can um, put their knees together, and usually one knee is shorter than the other, so that you actually are seeing a shorter femoral bone there. So um, those are the ways that you should tell. So, can we cause them to develop this? Well, we don't help when we do our swaddling. Our swaddling is a good thing for the babies to feel like they're being held. However, we need to be sure that we're not pulling their legs down straight. We want to make sure that we frog leg them, bend their knees, make sure their feet are in alignment, and we really shouldn't make their arms stay um, in there so much. So they should, when they're swaddled, their arms should be out so they can have some freedom of movement, suck on their finger, whatever they want to do. So the treatment varies, like we already talked about. So it depends on their age. 0 to 6 months. The first 12 weeks, we're going to do the pelvic harness, and then we're going to do the Bryant's for 6 months. If they're not, um, if after the 24 months of the Bryant's, we have not had any improvement, then we are going to see surgical closed reduction and a spica cast placed from the age of 6 to 24 months. So up to the age of 6 months, we can treat them with the Bryant's. But if, again, this is going to be after we've had them in the cast for the first 12 weeks of age, we can keep them in the cast up to 6 months more. So they could be about 9 months old. But your book tells you that in 6 to 24 months of age, if they don't have any improvement, then they start doing the surgical reduction. Now, the reason there's a little bit of disagreement with it, because the traditional got into this, that the 6 months of age up to 6 months, the Bryant's, and then it says 6 to 24 month surgical closure. That's basically what it is. If there looks like there's improvement with the Bryant's, and they're a little over 6 months of age, and there's quite a bit of improvement, but they want to have a little bit more improvement, they will leave them in there a little bit longer. But if they're not showing enough improvement by the age of 6 months and the time they've been in that traction, then they're going to go ahead and do surgical closure and put them in the spica cast. Then after 24 months, they're starting to look at a different type of treatment, because after 24 months, we can't use the pelvic harness. We can't use the anything like that. So it's harder to, after 24 months, they've been up walking for a year, and their femoral heads have adjusted, and they've been able to walk with these congenital hip factors. So they may have a strange walk, but there's not really a whole lot that they can do after the age of 24 months about getting them in there. They may try, some doctors may try, but up to about the age of 4, it's still difficult to get a successful reduction and reconstruction. And then after the age of 6, they really don't usually do anything. So it's very important that we recognize it early on and start treating it very early when everything is developing and growing rapidly. Don't double diaper or triple diaper your baby. It makes the situation worse. Teach your parents about how to take care of that pelvic harness. That harness has to be refitted often because of the rapid growth of the infant. Right at first, it has to be fitted every 1 to 2 weeks. Um, some physicians may let them take it off for bathing, some may not. Be sure you're doing good skin care. Um, put on an undershirt to prevent the straps from rubbing the skin, the knee socks to keep the straps from rubbing the skin, and be sure we're checking quite frequently under the straps and the clothing for breakdown. And again, like I told you earlier, you can massage the healthy skin gently that are under the straps, but if you've got a reddened area, you never massage because that could be the development of a skin breakdown. Don't use powders, don't use lotions. They complicate things. Put the diaper under the straps, not over it. You will have very dirty straps if you do that. And of course, you've got to encourage bonding with parents. Sometimes they think if they hold the baby with the straps that they're going to disalign it. It's not made to, it's made to work the way it is, and you can hold your baby. So you need to teach the parents how that they should be spending a lot of time interacting with their infant and just treating that strap as an additional piece of clothing that their child has to wear. All right, clubfoot. You notice the picture of the cast. The cast goes from the foot all the way up the thigh. And that's so that our hips are abduction so that we can keep our foot in alignment. There's a lot of different types of Talepes, which is clubfoot. I'm not going to expect you to know all the different types of Talepes. I don't think that I think that's a nice to know, not need to know. And so the most common one is the Talepes equinovarus. Equine is a horse, so that's kind of a horse-shaped foot is what they're kind of looking at. Now, this is the exact definition of it. We don't know what causes it. Sometimes it's abnormal positioning, restricted in movement in utero. It could be genetically dispositioned. If somebody in your family has it, they can develop it. It happens during the embryonic stage. So that would be in our first 8 weeks. And the deformity is the forefoot is abducted, the midfoot is in supination, your hind foot is in the varus situation where it's outward, and then of course you have an ankle that's equinus, which looks like a horse hoof. I'm not going to expect you to know all those details, but you need to know that the Talepes equinovarus is actually a word that's used. It is the medical term for clubfoot. We have tried to get away from saying clubfoot, but most people don't want to go around saying Talepes equinovarus. So most people don't know what you mean. But you say clubfoot, everybody knows what you mean. So our goal with these little babies, and they can be actually seen on ultrasound in utero so that you don't have to wait and see if you can figure it out when they're born, and it'd be a big surprise to the parents that they have a clubfoot baby. Usually when the doctor's doing his routine ultrasound, he can see if there's if it looks like there's some problems with the foot. Now, if it develops because of abnormal positioning, it may be that they don't do an ultrasound unless there's a problem in the pregnancy, and it comes as a big surprise to the family. So sometimes you have to work with getting the parents to accept the fact that their child does have a deformity, but we're going to try to fix it. Because what we're going to try to do is achieve a stable foot. We don't want it to hurt. We want it to be plantigrade. We want it to be sure that it's flat and it can actually stand on the foot, keep it in a plantar position, and it be stable. So basically, we want to correct the deformity. Then we want to maintain the correction, and then we want to follow up to avert any type of recurrence, because it can reoccur if it's not done completely corrected. Usually in the first 6 weeks, or actually, we actually are going to do serial casting with Telepes equinovarus. Um, Massaging the foot and stretching the foot is really not as effective as the casting is, but it is helpful. So we actually will do the serial casting, and when we do weekly gentle manipulation, well, there's not going to be a whole lot of manipulation you can do if the baby's foot is totally casted. You can't really manipulate the foot once it's casted. So usually in between casting, they'll try to stretch and get it back in the shape that it should be in. And you can see this baby is kicking his feet because they're not even, so they actually can move with those casts around, and those are plaster cast simply because we've got the small ankle bones, we've got that we're trying to get into alignment, small foot bones, so we want our cast to fit very closely to the body part. After we do the serial casting, of course, it has to be the long casting, and if we get them in place, we put them in the Dennis Brown splint to keep them in place, and sometimes we have to do surgery to correct the foot and go in and do a tendinotomy. They'll usually do that between the castings if the foot's not correcting as the way they want it to. So our care for this child is going to be the same as it is with any child in casting. You also want to consider their developmental age, always, always, always. Teaching the parents the importance of adhering to the treatment to be sure they're bringing that kid in and getting those serial castings done, keeping them in casting, and facilitating the development of their child is very important with this child. Then we have Metatarsus adductus varus, which is actually the result of some abnormal intrauterine positioning. We know it as pigeon toe. And we used to talk about the valgus, which was the knock knee, or actually the bow. Yeah, it's the bow-legged. The varus is the abducted, or the adducted, and the valgus would be the abducted. So we would have bow leg. But we're not talking about that because it's not in your book. So evidently, well, they don't want you to know about it. They want you to know about pigeon toe. Manipulation and stretching is usually done because if it's an in utero position, hopefully we can get it corrected by manipulation and passive stretching. If we don't get it corrected for 6 weeks, we may start casting them just like we do for clubfoot. They rarely see surgery. We identified early, of course, as good nurses that we are. Teach the parents how to massage and manipulate the foot by holding the heel firmly and stretching only the forefoot, not the midfoot, but the forefoot. Cast care if necessary, again, the developmental age and appropriate activities. One thing that breaks our heart a lot are the skeletal limb deficiencies when children are born without arms or legs, or partial arms or partial legs. It's usually underdevelopment of skeletal elements. Can be hereditary, can be environmental. Back in the 50s, 60s, they were given thalidomide, which didn't harm the babies that were born in the 50s, but the babies, female children that were born in the 50s, when they had children, we started seeing what we call flipper fans, where they have a partial arm, but just from the shoulder to the elbow, and it'd just be like a little flipper. Chorionic villi sampling. Chorionic villi sampling is a genetic marker, genetic testing that is done antepartum to see if the child has any genetic disorders. They used to do this routinely before they figured out that they were making flipper children that way, because they were doing it at a certain time when the arms were developing. So they narrowed the window down to 10 to 12 weeks. So you should never do it before 10 weeks, and preferably not after 12. So you've got to get that chorionic villi sampling right in that window of 10 to 12 weeks. So you want to really be sure of that gestational age. We will see, the amelia is the absence of the limb, and the meromelia is the absence of partial limb. What we're going to see clinically with these babies, we're going to see some bone fragility in their other areas. We're going to see, of course, deformities. Oh wait, I'm in the wrong section. Never mind. We are going to see some bone fragility though, because things are not developing, or we may see it. I'm not going to say we are going to see it. Stages, when we fit them with a prosthesis device at early stage of development is going to be at the earliest stage of development is going to be the best time. Like this baby right here is old enough right now to be fitted for some prosthesis for the arms to get them. It's usually we do those as soon as possible to encourage limb exploration so they will learn to use, even if it's just a little flipper mitten put on there to kind of get them to adjust to having a limb and the body recognizing the extension of the body. Um, when they start trying to sit and they have a lot of hand activities, this is going to help. Then we do the lower extremities when the infant starts to pull up and try to sit, um, begin to crawl. And sometimes we need to do surgical modification to fit the stump into the prosthesis correctly. They have really made a lot of strides in prosthesis for children. Some of them look so natural, it's hard to tell if they're wearing a prosthesis or not. Of course, we replace these prostheses as the child grows. When he's born and he's got little flipper on his shoulders there, you wouldn't expect him to have the same size when he gets to be about 2 to 3 months old. So they're changed often as the child grows. This can get expensive, so hopefully they have some kind of financial support. Some of the care that we're going to have to work with these children is training and rehabilitation, uh, treating them, trying to have them learn how to use their prosthesis. They're going to be seeing their prosthetic person often. Parents are going to be very devastated, and it's going to, especially if they feel like it's something that they've done. Say they opted to have the chorionic villi sampling done, even though they really didn't want to, and then this turned out, they would probably think that would be what was the problem there. Um, a lot of times they overprotect the kid. You want to make sure that they don't do that. We want to encourage the child in those developmental milestones. We want to be sure that we are doing play appropriate activities for the age. Osteogenesis imperfecta, brittle bone disease. It's your most common osteoporosis disorder, but it's very rare. But we do see it. I know you've probably have met a child or two sometime down the road, or you will. Heterogeneous autosomal dominant disorder is what it is. So genetic counseling should be done with any of the parents that have these markers. There's a type 1, there's actually several types of the osteogenesis imperfecta. There's like 7, 8 um, types. The two types I want you to know is the type 1 and the type 2. Type 1 is the one we see most often, and it is a mild form, mild fragility, mild, you'll have blue sclera. They'll have some deformity. They have fractures. They will have some hearing loss because those little bones in there. They have discolored teeth. Type 2 is lethal, and the babies are usually stillborn or die really early in infancy. So depending on their whatever type that category they fall in, depends on the type of care that we're going to give them. Someone with mild type 1 may not need as much protection as someone who is in the severe, which is on down. Sometimes they'll have some different things going on. Sometimes it's just a difference. One of the things that's real important with this is that what's going to show up in their labs is going to be collagen. They're going to have a lot of collagen, so you're going to be looking for that collagen in there, so that in their in their labs. Okay. How do we treat it? It's mainly supportive. We have to try to prevent. Prevention's the best. We can prevent their little bones from breaking. It's okay. Sometimes they just break on their own. They're very fragile. You have to be sure that you're diapering very carefully. You don't jerk on your child's arm to pick them up off the floor. Very careful handling. It's very supportive treatment. There's not a whole lot we can do about it. Sometimes when they go into puberty, they will have the hormones in puberty will sometimes help strengthen their bones, and it may help a little bit. Some of the new IV therapy that they've been trying to do is biphosphonate phosphonate therapy that they've been doing through the IV, is one of the newer things they've been doing for the last few years. The problem with that, it weakens the long bones, which prevents a lot of it affects the growth plates, but it does strengthen the vertebrae. We usually put these children in braces that they can walk in braces that helps protect their legs and gives them strength so that their own body weight don't crush their bones. Um, it's something you really need to rule out when you have a child coming into the hospital frequently with fractures. We tend to think child abuse. It's really hard to break infant bones, but it's easier to break as they get older. And if they're coming in with a lot of fractures, one way you can tell, one of the things you can look at if you're trying to determine just by looking if it's child abuse, there should be bruising with osteogenesis imperfecta. There is no bruising unless, of course, they've been hit, with something. But there's usually their fractures occurred. They can just be walking and have a fracture occur. So depending on how hard they put their foot down. These children can go to school. They can participate in any activities that they can wear protective clothing and protect their bones depending upon their severity of their bone breaking. Okay, let's go on to acquired defects. This is Leg-Calf-Perthes disease. We don't know what causes it. It's self-limiting, which is a good thing that it's self-limiting. It goes through those 4 stages of avascularity, revascularization, reparative, and regenerative. And that's pretty much self-explanatory as what happens. So the femoral capital epiphysis has ischemic aseptic necrosis due to the lack of circulation. So this happens because of the lack of circulation to the femoral head. There's not an infection there. There's not anything like that going on. So you want to be sure that you're checking for temperature. And if they run into temperature, it seems to be infection, then it's not Leg-Calf-Perthes disease. Leg-Calf-Perthes disease, because it's self-limiting, is a little bit better than some of the other ones that we're going to talk about. And some of these are so much similar, it's hard to figure them out. Usually happens during middle childhood when we're seeing a rapid growth. And for some reason, and they don't know why, the blood supply to the femoral head, the epiphysis, is compromised, and there's no vascular clarity, so the necrosis starts, and that's the first stage, avascular. And then for some reason unknown, the epiphysis starts receiving blood supply and starts revascularizing. So it starts getting blood supply, perhaps the collateral capillaries, whatever. And then we have reparative, where the epiphysis is going to start doing self-repairing, and we're going to really hope that it goes and makes a spherical femoral head and regenerate into that. So it goes through those 4 stages. Do we like to treat? Do we just let it treat itself? No, we really like to help eliminate the hip instability so that it grows correctly. So there may be some things that we're going to do here. The onset of it is insidious. Usually you notice a limp. Parents will usually see their child limping after activity, um, or after they when they get up in the morning, and they'll have pain in their hip. Sometimes it's an ache, sometimes it's soreness, sometimes it's just really stiff. Children that are younger than 5 have the best prognosis, and then 10 years and older have risk for degenerative arthritis later on in life. So even though it's self-limiting, if they get it at a certain age, it's really, it's they don't have as good of an outcome, and they will have some problems with walking and have arthritis maybe later on. We want to do the range, maintain that range of hip as much as we can and prevent that epiphyseal collapse from happening. Um, Again, it varies with the age of the child. We usually do those abduction casts just like we do with the congenital hip dysplasia. Immobilization is going to be occurring. We're going to give NSAIDs. NSAIDs are a drug of choice for almost any pain in children instead of aspirin. Of course, we want to be sure that with NSAIDs, we're giving them with meals um, so that they don't have gastric upset. We may end up having to do surgery to correct the when it starts to regenerate to shape the femoral head, or we may have to go in there and do some surgery elsewise. The best after surgery, of course, they're going to be casted, they're going to have to rest, and they're going to be non-weight bearing when they come out of their cast. Remember, these children are in initiative versus industry, and we've got to be sure that we've got activities that they can participate in, because this is really going to be hard for them, because they're not going to feel sick, they're not going to feel bad. They just are going to have to wait until this disease process works its way through from start to finish. So, and usually we don't notice it until the vascularization has caused enough necrosis for the kid to start limping. Slip capital femoral epiphysis is idiopathic. It's usually associated with endocrine disorders, which I've listed here. Multifactorial, it's also associated with obesity. This does not mean that skinny children cannot develop it. It's got to do with the facile architect. Sometimes when they go through puberty and those hormones are changing, and that's usually when you're going to see this happening. It's just a spontaneous displacement of the femoral epiphysis in a posterior and inferior direction. Now, we're not going to be able to tell that by looking to see if that's exactly what happens. So what we're going to see is when we've got children who are before or during that accelerated growth onset, usually 9 to 16. We usually can diagnose it when we see clinical signs of hip, groin, thigh, or knee pain. It's confirmed by x-ray. It is an emergency and it requires early diagnosis and treatment, or we will see vascular necrosis or avascular, or we will actually see necrosis, but the necrosis will not do like the leg calf Perthes disease. It does not regenerate itself, it just degenerates. We want to prevent slippage, and we don't want to develop avascular necrosis. We want to be sure that we're maintaining adequate hip function. Should be non-weight bearing. A lot of your surgeons, orthopedics, will do surgery 24 hours after onset instead of trying cast and things. They just, it's really a risky disease process that they could lose the use of their hip. So our nursing care is going to be the same as when they're casted, because after surgery they're going to be casted. Developmental age again, and of course immobility and the effects of immobility, because they are going to be immobilized. Kyphosis, lordosis, and scoliosis all fall in the category of spine deformities that they acquire. Kyphosis is usually just a postural one where the bones are outgrowing the muscles, and the muscles can't really hold up the body. So that's usually where you're going to see lateral angulation in the convex curvature of the spine. Remember, we learned how to assess the spine in physical assessment. They can put a brace on these children, or they can start doing postural exercises. It's not painful, which makes it a little bit easier to have kyphosis than lordosis. Lordosis is painful. Um, so lordosis, of course, is the curvature of the lumbar. So usually we try to manage the cause of lordosis. Many pregnant women have lordosis, so obesity can cause lordosis because you have such a large belly in front of you. So what we try to do is manage the cause. If it's obesity, we try to get them on lifestyle changes. If it's hip dysplasia that's causing it, we're going to try to correct those deformities. So we want to be addressing that. And we're going to give NSAIDs or Tylenol for the pain according to whatever the doctor wants to order. The one that concerns us the most is the idiopathic scoliosis, which can actually cause respiratory problems because you have uh, the shortening of the chest and the you have your spine at such a degree that we're not able to expand our lungs well, and our diaphragm can't expand. So we see problems with respiratory in here. It's a real complex deformity. Sometimes it can be a lateral curvature with spinal rotation and thoracic hypokyphosis. Now, this is my little stepdaughter has scoliosis really bad, and she's at by the time the first time anybody even that I noticed it and anybody else noticed it because she stayed mainly with her mother was the fact that she was getting an epidural, and the anesthesia person called me back to look at her spine, and it was just horribly twisted. I don't know how the child managed to walk because it is painful. And at her age, they offered no treatment. So usually we see it age 10 or later. It happens more in females than males. We don't really know the causes. It can be caused by a lot of things. We usually find it when we do the school screenings. Um, Sometimes because you notice ill-fitting clothes. We observe them. Of course, we do the screening. They go to the doctor. They get some x-rays done. We have a scoliometer that we can measure the angle of the truncal rotation. Our radiology, our radiographic curves need to measure at least 10 degrees to diagnose that they have scoliosis. And it can be up to 25 degrees, and we're not going to treat. We're just going to observe to see if it gets worse or not. Hopefully it won't. But if it gets over 25, we start doing active treatment such as bracing. When it gets over 45, when it gets 45 or more, we start doing surgery. Um, so we start out with bracing. Parents need to know, and the child needs to know, putting you in this brace is not going to cure you. You're going to have to wear this brace for a long time just to help you keep your spine in alignment, try to slow down the progression. There's different types of braces that we use. Boston, Wilmington, the Milwaukee brace was the one that was really popular years ago. No longer use it. Just remember, with brace care, they're usually fitted to their bodies. They usually have a Velcro opening where it can be adjusted for comfort, but it has to fit snug so that, and they have to wear it 23 hours out of 24. They can take it off for an hour and take a bath. Compliance with these braces is a little bit difficult because of body image. Exercise alone does not help with this scoliosis. It's only therapeutic if it's done in conjunction with braces, so it helps the muscles develop as they grow. Um, some of the things that we have to do when we have to go in and do surgery. We, of course, preoperatively do all those checks with our films and our labs. But the most important thing is that we have to consider hypovolemia in these children because, for one thing, this is a very long, drawn out surgery. So they have a high risk of losing blood. Um, so, we need to talk to them possibly about if they want to donate their own blood beforehand, before surgery, and build up a bank. Talk about possible blood salvage during surgery. Um, Whatever we need to do because we're most likely going to have to give blood after surgery here. We want to teach them about using their PCA, that we're going to be doing log rolling. They can't be moving and rolling around by just themselves, or have a how to get up and without doing damage to their back. Chest tube if we're going to need one. We're going to have a Foley catheter. Um, Post-operatively, these people used to be kept in bed for weeks or in a scholar frame for a long time, protecting their back. But surgery has come such a long way that even though what we're doing is still the same thing, we're still putting a rod down their back and we're fusing their um, bony prod. We're doing some fusion with their vertebrae to try to keep their spine aligned and yet give them enough movement in their spine, although they're not going to be able to do much movement with a spine with a rod in their back, are they? So we've got to teach them things like that. And then after they have surgery, of course, we don't want to, when we're moving them in bed, they should be log rolled. There should be 2 people at least in there to do log rolling, pressure relieving mattresses. But the thing about this, and neuro checks are very important, and vital signs, checking for Elias. These are all things that are important. Our biggest thing with the patient is going to be in a considerable pain. So we need to make sure that we're taking care of their pain as well. They'll need that morphine to help take care of their pain. Now, instead of keeping them bedridden, we do ambulation as soon as we can possibly get them out by the second post-op day. And we always have to make sure that we're doing INO and fluid and electrolytes because when we do surgery, especially that extensive of surgery, it can affect the rest of our body. So we also have infection of bones and joints. So infections of bones and joints starts out with osteomyelitis. Miss Medley's going to talk about osteomyelitis. They think this is a little more prominent in adults than it is children, but children do get osteomyelitis from puncture wounds if they step on something or have something puncture them and it goes into their bone. It's a local infection. If they have tonsillitis, upper respiratory infection, something like that, then it's a systemic infection, and that's what makes this so hard to heal. It's because the bacteria just gets in there and adheres to that bone, and pus starts developing, and inflammation develops. We start seeing a lot of edema and some thrombosis going on. So it's really very painful. Osteomyelitis it causes bone destruction. We're going to see that abscess formation that we'll need to go in and aspirate for um, the pus to make sure that we are getting a culture. The dead bone that it causes, which is the bone destruction, the dead bone's called sequestra, and sometimes they go in and do a sequesterotomy. Usually in children, the infection is contained by the growth plate, and joint infections less likely. And that's the same as with the neonate. Whereas with the older adult or older adolescent, we're going to see that it's poorly contained because their growth plates have completed, and so it's not going to be able to contain them. There'll no longer be a growth plate there, and the joint is compromised. So we see infection in the joint as well, as systemic wise. So that's why osteomyelitis is just a very terrible bone infection to get. We can cause this by doing heel punctures for our PKUs on our neonates. That's why you have to be very careful not to go any further than so far um, with your little stick. We got to, of course, before we start any antibiotics, we've got to make sure to get our cultures of the purulent drainage. So we're going to have to aspirate that. We're going to have to do a blood culture. If the joint's infected, we're going to go in there and get some of the synovial fluid. We're going to even culture infected skin if that is, if we see that. If it's localized, then we'll see it there. If it's systemic, we won't. So after we get all of our cultures drawn, when we start our IV, we draw all those cultures, right? Then we can start IV antibiotics. Nafcillin and clindamycin are two of the main drugs that they will start you out on until we get the cultures back. If we get a culture back that they have MRSA, we will switch all that over to vancomycin or possibly keep on clindamycin. Depends on the culture. It will take at least 3 to 4 weeks or longer of IV therapy. They won't be staying in the hospital. Again, they'll stay in the hospital for so long, and then they can go home on infusion care at home. If you're going to send a child home, you certainly don't want to use a peripheral IV. So we want to probably get a PICC line. PICC lines are the most wonderful things, and they can last up to 6 months or longer depending on if it's still working or not. So after they have that 3 to 4 weeks or longer of IV therapy, then they will follow that up with oral antibiotics, and could be up to 4 months of oral antibiotics after all of the IV antibiotics. Surgery is done if we don't have any response to drugs to go in and remove the infected bone, and of course remove the dead bone. They don't like to do surgery if they don't have to. They prefer to do the antibiotics. They can't. The way we're going to take care of them is we're going to make sure they're positioned good. We're going to splint the involved joints to make sure that we don't have contractures. We're going to support the affected limb. No weight bearing, so this child is not going to be able to get up. They're not going to feel well. With osteomyelitis, they don't feel well. They run a fever, they have a lot of pain, they're irritable, and these are things we have to deal with. Be sure we're assessing our IV site often if they have a peripheral, and of course doing our PICC line changes, dressing changes as we need to do those. And we use standard precautions, make sure that we don't infect them anymore, and we don't get anything spread from there. With the septic arthritis, we have, I just can't stand it, guys. I hope it stays there. They should be down further. Should be right there. Okay. Septic arthritis, the bacterial is a bacterial infection of the joint. So most arthritises are where? In the joint. So this is a bacterial arthritis, and so this is going to be very painful. Of course, it usually is in the lower extremities rather than the upper extremities, caused by Staph aureus. If you get it in the hips, then we can't. Then it's an emergency. It is a big emergency if we have it in the hip. So we want to be sure that we are getting treatment as soon as possible. You will see fever, malaise, headache, vomiting, nausea, irritability. Aspirate. What we're going to do is aspirate the fluid from the joint for cultures. We're also going to do leukocyte counts and a blood culture. We'll treat it with IV antibiotics, pain medication, again, try to prevent contractures by positioning and splints, and then we're going to start physical therapy. We're not going to start the physical therapy until we can actually get the bones in control. And when you have arthritic pain, you do not want to use ice as part of your treatment. You want to use warm packs, warm water, warm baths. Cold is not good for any type of arthritis. Would we want to put heat on a bacterial infection of the joint? That would probably not be the best solution because it could cause the infection to spread. So we want to make sure we know the difference that treatment for septic arthritis versus our juvenile idiopathic arthritis we're going to talk about in a little bit. Skeletal tuberculosis, I'm mentioning it very briefly. It's an infection in the bones that's going to be caused from having a primary infection of TB. It's not common in the United States. We're going to give the same type of drugs we would give for the TB um, respiratory in the lungs, and of course, we're going to put them in isolation until we have them treated enough for that. We want to be sure, we would prefer to do direct observation therapy to make sure that they're taking their medications, because a lot of times they don't. Okay, then we have tumors. We have osteosarcoma, we have Ewing sarcoma, and we have rhabdomyosarcoma. So none of these are good. They don't have the best outcomes. Um, it depends on the state. The osteosarcoma is the most common. This is the most common bone we see. It usually arises in early development, in when we start having the mesenchyme develop, mesenchyme develop during when the embryonic is making the layers for the skeletal, for the skeletons or for the bones. Let me put it that way. And that is what's going to give rise to your malignant osteoid tissue. So this is actually during embryonic stage when this is being laid down. Uh, when this mesenchyme, well, maybe not the embryonic, yeah, it'll have to be the embryonic where this is going to develop, because all of your tissue is developed there. But it's going to develop from the bone portion of the bone, not the inside of the bone, but the outer portion of the bone. How do we fix it? We go in and do surgery at the affected area. Um, Chemotherapy, usually do methotrexate with another chemotherapy drug. Limb salvage, which is just going in. If they have a tumor on their upper femur, they'll go in and remove the majority of that femur and the femoral head, and they'll do a total joint hip replacement, trying to be sure that they get all of the cancerous cells that are in there. And of course, there's a high incident of amputation in osteosarcoma. I know several of you have seen a lot of children that have their lower limbs, because this is lower limbs are usually where we're going to see this in that long bone. So kind of depends on the type of surgery done as to what care we give. You know, if we've had limb salvage, of course we're going to take care of the surgical site. We're going to make sure that everything's doing the therapy and stuff that we need. We want to make sure that when we're talking to the family and to the child, we don't say you have a little infection we're going to try to take care of. They need to understand they have cancer and there's a high probability they will die. And they need to understand that, because when you go to do amputation, they need to be able to accept the fact that cutting off one of their legs is the only way they're going to live. And because it's hard to accept the fact you're going to get your leg cut off, you know, especially for children. Uh, then, of course, they're going to have side effects of the chemo. One of the things you can do to help children that may need to have amputation is to introduce them to other children who may have had amputation due to the same thing. And of course, you want to be very careful about the kind of children. Some children don't adjust well, so you want to be sure that you introduce them to a well-adjusted child. They're going to be fitted immediately with a temporary prosthesis, because if we don't fit them immediately, then they have to have stump care, which could be a prolonged process, and then they won't be able to get their prosthesis early. So we fit them with a temporary one as soon as we do the amputation. Phantom pain is real sensations that they feel, and they need to realize that they may feel that leg hurt even though it's not there. Amitriptyline is the drug of choice for children to give for phantom pain. They have been trying to prevent them from feeling phantom pain by doing spinal epidurals, um, so that the cells don't have any memory of the pain, and so the nerve endings won't send out pain signals from that leg, uh, because they don't have any memory of it. I think it's a pretty good idea. Um, with Ewing sarcoma, it's the second most common. It's going to arise in the bone marrow. Um, they have a 3-year survival rate. They usually don't have a very good outcome prognosis. We do limb salvage. We do radiation therapy. We do chemotherapy. Um, Again, they need to know the side effects of chemotherapy. Try to be positive. You know, if you're going to have to tell them their hair's going to fall out, say, yeah, you're going to lose your hair, but oh man, there are so many cool hats out there. And look, you could be a redhead one day and a brunette the next. And there's always things that you can do to make it a little bit better. Um, and to make sure that, you know, mom and dad know all the side effects. If they're having radiation done, they need to wear some loose clothing because they're going to have those radiation burns in the areas that they're trying to treat the tumor at. Rhabdomyosarcoma is the most common soft tissue sarcoma. It occurs in a lot of different sites because it's in the tissue. Um, and usually the head and the neck is the most common. Usually occurs in children under 5, and it arises from the embryonic development. So how are we going to diagnose it? Well, we're history of, do they have nodules coming up in their head, around their head or their neck or anywhere else in their body? Take x-rays, do CTs or MRs. Chemotherapy is going to be used. We really need to evaluate to see if any metastasis has happened. So we need to be sure we're doing careful staging. So there's a box in your book on page 1083 that shows you how they stage the tumors. And once they stage them, it's a lot like doing adult staging in oncology and in any of your cancers, that at certain stages they use certain types of treatment. So they have to be sure that they're staged correctly to do the correct treatment for that. They'd like to remove the tumor, do chemotherapy and radiation. Um, we want to carefully assess our child for possible returns of these rhabdomyosarcomas, and we want to be sure our child knows that they're going to go through a lot of testing, and mainly we've got to give a lot of supportive care. Juvenile idiopathic arthritis is our last subject to talk about. This is a chronic autoimmune inflammatory disease, and they diagnose this based on age. You have to be younger than 16 to qualify for having JIA. Used to be called JRA, but now it's JIA. We used to see a lot of commercials about this. Don't see this much anymore, but we used to see a lot of this. We don't know why they developed this. Of course, it's characterized by that chronic inflammation of the synovial joint effusion and eventually erosion, damage to the joints. Um, our outcome is variable and it's unpredictable. It's rarely life-threatening, but it's terribly disabilitative. Um, the kids can't get up and run and play and do things they would like to do because they are in so much pain. And then, of course, their joints are having damage done to them as they have all these exacerbations. Some of them will have remissions for a long time, and some of them won't have any remissions at all. Nobody knows why or how it goes that. There's many classifications of JIA. Don't particularly concerned about you knowing all of the knowing the classifications, but please read over them so you're familiar with them, on page 1084, but don't try to memorize them. I just want you to be well aware that there's just, depending on the involvement of what, as to what classification they fall in, the care is the same. We diagnose this juvenile idiopathic arthritis by exclusion of everything else. We've looked at, if they're having hip joint pain, we've looked at Legg-Calvé-Perthes disease, we've looked at slip femoral, we've looked at maybe congenital hip dysplasia, we've looked at anything that might be causing it, and none of that pans out, and so the only thing left is juvenile idiopathic arthritis. They did if it's unless and the only way that it's a different type of arthritis is when it's that septic one that's caused by bacterial, and the bacterial arthritis can be cured by taking care of the infection, whereas the JIA is not. We have no cure for it. We have our major goal is going to be to help control their pain and not have try to prevent as much damage as we can and prevent them from losing their use of their joints. Again, we want to promote their growth and development. They're in early stages of puberty. They are realizing there's boys and girls out there. We try to do all this care by outpatient care. Some of the medications that we give, methotrexate is largely used for arthritic pain. If methotrexate doesn't work, then they can go to Embryol, but it is a little bit more of a biological agent that has a lot more side effects than methotrexate, so they start with methotrexate first. And when they get to using the other medications, we really want to make sure that we're watching out for that. Some of the side effects of those biologics are they're at increased risk for infection. It can cause them to have a lot of demyelination diseases, can affect their pancreas. And before we start treatment with those biologics like Embryol, we should check them for TB to make sure they don't have a tuberculosis infection. If we gave that drug and they did have TB, then that would be a death sentence for them. The corticosteroids, of course, are going to cause them to have a low immune system. So we're already giving them chemotherapy, steroids, biological agents. These three things right here all are going to suppress the immune system. So one of the nursing care things we need to make sure we're doing with our kids is assessing them and keeping them away from infection, preventing the infection, because it's so easy for them to develop it. Again, NSAIDs is a choice, drug of choice. GI upset, something we need to watch for, is always give with food. We can start with physical and occupational therapy. Someone who knows what they're doing needs to be doing this because a lot of times the joints are so painful that there's no way you can do this. So you have to do all these other things to get rid of the pain before you can actually start physical and occupational therapy. Using your joints in arthritic patients is very good for them to do. It helps preserve the function by using them. But sometimes it's so painful that they avoid using them, and then they develop the contractures and they lose the use of that joint. Some things we can do with our kids is, warm baths when they first get up in the morning, warm packs to their joints. Don't use any ice. Be sure that they've got a well-balanced diet and get the proper exercise and sleep that they need. And when they're sleeping, you can put them under an electric blanket because warmth helps the joint. So if you don't have electric blankets, sleeping bag, something that maintains warmth while they're sleeping. And that is the end of this particular slide. So I always try to turn it back on.